moderators, and as well to the Society for the chance to talk today. I have no disclosures. Many would argue that mediastinal lymph node dissection is the gold standard for staging in non-small cell lung cancer. And as we just heard, video-assisted thoracic surgery has certainly increased, and sufficient data to show the improved quality of life and pain outcomes, although a randomized study is now in progress. However, there is concern that compromised mediastinal lymph node dissection does occur with VATS approaches versus open approaches. There has been some suggestion that robotic-assisted VATS can produce mediastinal lymph node dissection similar to open approaches, and that the complication rates may also be similar to open approaches when it comes to the mediastinal lymph node dissection. A large multi-institutional series by Park and Melfi et al. Did show 24% upstaging rate with robotic-assisted VATS, similar to the open surgery procedure. And we just heard from the first presentation, much of this was due to N1 nodal upstaging. They did not compare this to open rates, but it rather did not compare directly to an open cohort, but this was similar to open rates. A very recent report by Bryant and Cerfolio et al. Did show increased rates of chylothorax in robotic-assisted video-assisted thoracic surgery. And in fact, in this study, in a multivariate analysis, RVATS was, or robotic video-assisted thoracic surgery, was an independent predictor of chylothorax. Our program was started in 2002 with Bernard Park, who really takes the credit, I think, for starting this program for our institution. In 2010, with the coming on of 2 new partners and the new robotic platform, we did switch to a 4-arm portal approach. In our anecdotal experience at that time, we did notice an increase in mediastinal lymph node dissection complications, particularly chylothorax and recurrent laryngeal nerve injury, although subjectively we did find the technique to be technically advantageous. So the objective of this study was pretty straightforward. It was just to review our mediastinal lymph node dissection associated complications since inception of the 4-arm portal RVATS pulmonary resections, all of whom undergo routine mediastinal lymph node dissection at our institution. This is a retrospective review of the prospectively maintained database. All patients undergoing segmentectomy, lobectomy, or bilobectomy were included in the study. And specifically, we created for all patients having a complication of chylothorax or recurrent laryngeal nerve injury, and we compared these complications to historical contemporary cohorts during the same time period of open and VATS resections. So during the time period, 250 patients went robotic-assisted pulmonary resections from 2010 to 2013, since the inception of the program. There was a 4.8% incidence of complications, 11 patients had 12 complications, 6 of each recurrent laryngeal nerve injury as well as chylothorax for an incidence of 2.4% each. Major complications or grade 3 by common terminology criteria of adverse events. 4 patients with recurrent laryngeal nerve injury did undergo bedside vocal cord medialization, and 3 patients with chylothorax did require interventional guided embolization or maceration of their thoracic duct, all with resolution of these complications. This is a specific table showing each of the patients. I know it's small, I apologize. I will just guide you through it. 9 of 11 patients were, or 9 of 11 of the resections were right-sided. Median lymph node counts in the right paratracheal, level 4, 9 with a range of 1 to 23, and the subcarinal region 6 with a range of 1 to 10. And most of these patients were stage 1 non-small cell lung cancers, stage 1 or 2. As far as the incidence of recurrent laryngeal nerve and chylothorax when compared to an open and VATS cohort, in our open experience of approximately 4,000 patients operated on during the same time period, 0.5% incidence of recurrent laryngeal nerve injury versus a 0.9% of chylothorax. In our VATS experience during that time, very similar numbers to the open experience. In the shorter time period, but and not as many numbers, however, we do see an increased rate of chylothoraces and recurrent laryngeal nerve injury, When we compare the open versus the robotic or the VATS versus the robotic, there's a significantly increased rate of these complications. There's no difference in our experience between the open and the VATS experience. The summary and some considerations: chylothorax and recurrent laryngeal nerve injury do appear to be increased in our robotic-assisted pulmonary resections. We surmise this may be due to some technical considerations and adaptations that were done during the robotic inception here, including decreased use of clips during paratracheal dissection, perhaps increased use of cautery. This may also be still a part of the learning curve phenomena for relatively recent adoption of this particular technique. And one consideration, it may be a marker of improved MLND with complication rates similar to open, which have been described at these rates in other series. Also needs to be considered what the clinical significance, again, of a more aggressive mediastinal lymph node dissection is in these early stage patients, and to weigh the risk-benefit of perhaps over-aggressive mediastinal lymph node dissection with better technology versus more judicious dissection. Limitations: it is retrospective, it is single institution experience, and the numbers are relatively small, especially in our robotic experience. Conclusions: at least subjectively, RVATS does allow for technically thorough mediastinal lymph node dissection. However, we do see higher complication rates with the robotic approach. Technical pitfalls must be identified and corrected. And further prospective study, I think, here is warranted to track these complications and see if they truly are greater just associated with the robotic approach. Thank you very much.
Thank you very much. Very nice, and I think very important report. I think I also had the impression, that this occurs, and I think it's a technical thing. You use electrocautery for dissection.
Yes.
Yes. And I think you have even if you use a bipolar, sometimes you have the electricity going from the instrument to the side because there is no insulation. And I think this makes it. And my conclusion was to use more, as you also put it out, more clips to do the dissection and use less the bipolar. But I think these early reports, even the numbers are not so high, and of course your rate is still quite low. I think it's very important. Thank you very much.
Thank you. I agree. In some sense, we've made a departure from what we would normally do open, and getting back to those basic principles may again bring those rates of complications down.
Yeah, Jose Rodriguez, Dayton, Ohio. Just a couple of comments. When I trained, everything was open in UAB, and then I tried to do VATS lobectomy, and I hit a brick wall because I thought that the lymph node dissection was very difficult. And the surgeons that can do lymph node dissection as good as open with VATS, that's pretty impressive, but at least not on my hands. And I think robotics, lymph node dissection is easier, I think. Visualization is better. And you don't have that problem that you mentioned in your introduction that you might don't have a good lymph node dissection with the VATS, which I think is correct if you don't know how to do it. Robotics, I think, is easier. Interestingly, is that you're using using bipolar for the lymph node dissection or using a spatula?
Really, cautery spatula.
So when I was starting after training, I have a few chylothorax. I don't know what's because lack of experience, but now in doing robotics in the last couple of years, I do not have any chylothorax. I'm using the bipolar curved tip, the same one I think you use for your esophageectomies. Mm-hmm. I don't know if that's the reason or just more experience, but I think that using the bipolar in the subcarinal area is very helpful to avoid those problems as well as the inferior ligament. Just a comment. Do you use a spatula all the time or in the subcarinal
We do use a
area?
spatula, and I found that the energy devices, especially when it comes to the lymphatics, may or may not seal them. I think it would rarely actually seal the main thoracic duct, just coming across it with an energy device, and really we think requires really ligation. But for larger lymphatics, and many of these chylothoraces may in fact be large perforators off the thoracic duct and not a true thoracic duct injury that do lead to significant amounts of lymph leakage, where clips are probably the standard there to really try to seal those leaks. And the energy devices may seal them in the short term, but the lymphatics may not have sufficient protein in the wall to really allow for a good seal.
Correct.
We don't know that for sure.
Yeah.
I haven't found that the bipolar has decreased those rates, but that's certainly something to consider.
Yeah, maybe my subjective experience is that the curved bipolar is a good one to avoid leaks, but it's just subjective.
Okay, thank you. One last short question, please.
So just a technical point, totally agree. I think if you use the bipolar and you don't bluntly pull the lymph nodes out, you don't get the leak. I generally don't think it's a major thoracic duct. It comes from the lymph nodes. I use bipolar, and I've seen it in less than 1%. And it hasn't required intervention, except in one case where it was persistent. So my question is, what was the difference in upstaging between the VATS experience and the robotic? That, you know, the robotic enhances the mediastinal lymph node dissection at the expense of increased chylothorax. Was there a significant difference in the upstaging?
It's a very good question, and something we considered looking at and did not as yet, and it's probably a good subject for a future analysis. Our real focused goal here was to look at the complications, not necessarily the role of mediastinal lymph node dissection. I agree completely with that. If we're not significantly changing rates of upstaging, then tailoring back maybe a little bit the over-aggressive mediastinal lymph node dissection that perhaps the increased visualization and instrumentation allows you to do with a robotic approach may be appropriate, especially in those early stage GGOs without any solid component that we think, without any clinical evidence of lymphadenopathy, where a less aggressive lymph node dissection may be appropriate. But it's an excellent question. We have not looked at that. I think we should.
Thank you very much.
Thank you.
We move on.